We worked with the Taimaka project in Gombe State, and we worked with IDEB Pro in Kano State. You may see that all of these are small organizations that really focus just on one geographic region. So we want to uplift those partners, and they actually deserve a lot of credit because they led the implementation of this pilot in their respective states and regions. And of course, I also want to thank the NEMSHEET team, and I want to thank Ministry of Health for your support. As you recall, we met a few months ago to discuss this project, and as promised, we're here to share an update. So thank you for having us here today. The partner NGOs, how do they actually implement this pilot? What they do is they liaise with state and local government to secure the appropriate permissions that are needed. They also engage with stakeholders, which means the PHC leadership and the health workers themselves, to ensure that the health workers actually take the course. So the local partners were doing all of the interaction with local government and with the beneficiaries of the program. Our objective in this pilot was just to train about 100 healthcare workers in newborn care in each of 3 different regions, and then to measure some simple outputs, like how many of them completed the course, what did they learn, and what was their feedback. Those are the outputs here. This is just a feasibility pilot. We weren't looking at impacts on clinical practice in this particular pilot. And HealthLearn's role in this was to provide the technical resource of the course itself, to provide technical support to anyone who had issues in the course, to provide technical assistance to partners, and we also gave small grants to partners to help them in their implementation. And we're here today to collaborate with you to talk about possible pathways to scaling up this work. But before I share the results, I wanted to invite Amarachi to just share some of the experiences in actually implementing the pilot. How was the pilot actually implemented here in FCT? So over to you.
Thank you. So we worked with HealthLearn as the implementing partner for the pilot course. What we did was, in order to achieve that effectively, was that we worked very closely with the local government authorities and the PHC leadership. So we secured approval from the AMAC LGA, working directly with the Director of Primary Healthcare, AMAC, who put the coordinator for maternal newborn health and family planning in charge of the project. So once we secured approval for the pilots, we got a list of 100 health workers that were directly involved with delivery, that attend beds and that have WhatsApp on their phones to participate in the course. So she gave us that list, and then also indicated in the list who were the PHC leaders in each facility, and also they were also arranged according to their clusters to make it easy to locate, the PHCs. So once we got that list and we had the approval, we created a WhatsApp group where all of the 100 participating health workers were added to the group. Those who we could add at the moment, because along the line we discovered that most of them, their numbers were not available. The numbers that we had officially from the AMAC LGA were not on WhatsApp. So we had to call each and every person on the list to say we're unable to reach you on WhatsApp. And then the feedback that we always got was that this is not my WhatsApp number. I have a different phone number for WhatsApp. And then by the time we're done with that and ensured that everyone was on the group, the course was launched on the 5th of September, basically by sharing the link to access the course. There was also a link directing them to a video that provided guidance on how to navigate the website and all of that. We also had our team members on the group who were highlighted. If you have any challenges, if you need help, these are the numbers to reach out to. We are here to help you. Provide answers to questions, continue to promote uptake of the course. We did that using the WhatsApp group, and we found out that they were very enthusiastic. They were really, really excited about taking the course, and they were getting the certificates and posting on the group and, sharing, feedback and their learnings. We also visited primary healthcare centers, 10 out of the numbers that we had, so that we could have close interaction with them, discuss ease of accessibility, how they were able to access the course, how relevant it was to them, and the response and the feedback was really, really exciting to hear. Calling them, we also had issues of people, the Nigerian factor, telling them to click on links. A lot of people thought we were scammed. They're like, where are you from? Who gave you my number? Prove who is the person in LGA that gave you my number. So I found myself describing Mrs. Eunice so many times. I'm like, it's okay. You just need to click on the link and take the course. And it kind of helped, just hearing that someone was explaining to them, kind of dispelled their doubts. Also, when they eventually agreed to be added to the group, seeing that there were other health workers on the group, there was interaction, and they felt comfortable, and we had like increased uptake of the course. Literally, we had about 75% completion rate in AMAC. So it was exciting, talking to them, getting their feedback, and then calling each of them on the phone. That really helped see that they took the course and that it was relevant. Yeah.
Thank you, Amarachi. Thanks for sharing that. And also, Amarachi has shared some of the feedback and some of the challenges, which we'll talk about again near the end of this talk. So I just want to summarize some of the pilot results, and this is looking across all three of the regions, not specifically at FCT. So first of all, we had 342 people in total who took the course. This is more than the 300 who were asked to take the course, or 299 who were asked to take the course. And that's because some folks recommended it to their friends and colleagues as well. Out of the 299 who took the course, we had 75% complete in AMAC LGA. We had higher completion in Kano and Gombe State. So across the board, we had 87% of those who were asked to take the course completed. And almost all of them had some clinical training. So it was about half community health worker roles and about half nurses and midwives, which of course makes sense. These are the folks who would be attending births. And almost 70% were being asked to take the course by a supervisor. We think that this is relevant because in all health systems, the engagement of supervisors may be important in terms of enforcing the practices that are taught. And then finally, almost everybody took the course on a smartphone, which of course affirms our decision to focus on something that works well on a smartphone. Here we're looking at self-reported data on what clinical responsibilities the health workers hold. Almost 90% indicated that they attend births, and almost 90% indicated that they provide antenatal care, whereas almost 60% indicated that they are actually supervising other health workers who attend births. And only 3% of the total did not choose at least one of these roles. So this means that we're really reaching a target audience of birth attendants and those who supervise birth attendants. We also asked them about when was the last time that they completed training specifically in newborn care. About 25% said they had never completed such training. In follow-up interviews, we found that this may be because in some cases, folks are transferred from other units into maternity, and so they are entering this from other clinical areas. And over 40% indicated that they had not been trained in more than 12 months. So this means that about a third of participants had received training in the last year in newborn care. And then we measure objective learning gains using a pre and post test. So this is a series of questions on essential newborn care practices that are the practices taught in the course. And the same questions are given at the beginning and at the end of the course. What we saw is that the pre-test scores on average were about 63%, and that increased to about 83% on the post-test. And this is a significant difference in the group as a whole, but also in each of the three subregions where we piloted. So in FCT, Gombe, and in Kano, we had significant learning gains. And then finally, we asked participants for their feedback. So over 98% agreed that they enjoyed the course. We were satisfied with this result, but also almost all of them agreed that the course was relevant to their work. This makes sense because we're targeting an audience of birth attendants, but also I think validates that the content is relevant to day-to-day practice for these health workers. And then finally, we asked whether they intended to implement some of the best practices that also align with Nigeria's guidelines that were taught in the course. So we asked about 3 different practices: delayed cord clamping, coaching the mother to initiate breastfeeding early, and initiating skin-to-skin care immediately, and sustaining it for the first hour after birth. And over 99% either agreed or strongly agreed that they intended to implement those practices. And then finally, in follow-up discussions, both in WhatsApp and in individual discussions with the health workers, we asked them what practices have they changed. And they highlighted different practices, including administration of vitamin K, skin-to-skin care, delayed cord clamping, etc. So although this is just qualitative data, qualitative evidence, we do feel that this suggests that the health workers are updating their practices to align with the guidelines. And then finally, we were surprised to hear many of the participants talked about cascading what they had learned into their facilities. So we can imagine that even if only a few health workers or in charges are trained in facilities, that this can cascade throughout a facility and even spread beyond facilities. So just to summarize some of the lessons learned that we have learned as HealthLearn, first of all, we think that this type of training is accessible to many PHC-based health workers here in Nigeria. And I think that's relevant because before we ran this pilot, the key question was feasibility. Can we actually reach this audience? I think the results suggest that we can. Now, the percentage uptake that we had is quite high. We were able to invest more effort in this pilot than we might be able to at scale. But still, I think that's an encouraging result. Secondly, as our partners have highlighted, the social interaction of the health workers in WhatsApp was really important. Hearing from their in-charges that they should take this course was very important. So tapping into existing networks can be a powerful way to encourage uptake. I want to emphasize again, local leadership. We don't have an understanding of the local system, but working with the partners, working with state and local governments really allowed us to run this pilot. We did identify some technical issues with the platform. We have actually developed a new platform that addresses, we hope, most of the biggest technical issues. The ones that I would highlight are network speed. Of course, networks aren't always great in some of these locations. So we've designed a platform that is even more low bandwidth than the first one. Secondly, some folks use old devices that require updating before they could access a course. The new platform that we have works on more devices, including some of these old devices. And finally, any changes in navigation can cause confusion. So we've simplified the interface even further. However, the implementing partners did identify some operational bottlenecks. Amarachi already talked about having to call some of the health workers to verify their phone numbers. And I was wondering if you could speak to some of the operational bottlenecks and also some of the feedback that you received from participants. Over to you.
All right, so when it came to feedback, it was really exciting to see these health workers excited, the exuberance when we interact with them and ask them. It was just that seeing that one of them specifically said that, she thought it was film trick, watching all of that, and then she decided to implement it. So we saw behavioral changes, immediate behavioral changes, if I would say. People adopting practices that they had earlier not been doing. And I know that one of such practices was the skin to skin practice, where they keep the baby on the mother and the baby crawls, finds the nipple and starts breastfeeding, leading to early initiation of breastfeeding. We found a number of health workers implementing this practice as soon as they saw it happen in the course, right? So those were practices that were demonstrated that we began to see results from. And we know that these are practices that we should, help these health workers provide, that helps them provide the quality care that we want to save the lives of these newborns. So we were practically seeing them doing these things. We heard most of them talking about the course being a refresher. Some of the things that they had forgotten. Someone said she hadn't even seen, some of those practices that were demonstrated. So it was really good to hear them see it. And from what he said, this was a life scenario that was being presented, and they asked, they respond. There were integrated videos that helped them even see practically what was being done. So they went back, we saw them doing these things, and it was really exciting to hear them talk about those practices and how they had started to implement it. Also, we saw that they were the ones now recommending the course to their colleagues who were not even on the list that we had. So they would recommend the course to them, and they would be reaching out saying, I had people calling me saying, thank you so much, I took the course, thank you, this is very relevant to the work that I'm doing, it has really helped me, thank you so much. And they were asking for more. I had one of the health workers that said, we need a longer course, we need another course covering this. They also talked about how it was convenient for them to take it at their own pace, at their own convenience, because it was self-paced. So we saw them talking about not having to be gathered in a place and being able to take it at their own convenience, that was really helpful for them. They were able to take notes, they were able to look at it. One of the operational bottlenecks that we had shared with HealthLearn was that they couldn't go back in the course. So the course was designed in such a way that it brings you back to where you stopped, such that if you stopped at module 3, when you come and you log in again, it brings you exactly to module 3, so you don't have to start afresh. But it now affected people who wanted to go back and go back to what they had seen, and maybe, oh, I want to see that again. When you're watching something and you want to rewind, or they couldn't do that. So that was one feedback that we continue to get from the health workers. Aside that, that completion rate and the excitement and the exuberance that they showed was a testament to how impactful the course was, how relevant it was to their work. The behavioral changes that we started to see, it was immediate, was a testament to the fact that the course really helped them, and it's something that we need. I also think that it is an innovative approach, especially in the settings that we have, even in the country, where every forward leader is thinking, how do we achieve maximum impact with the lowest possible resources and in the shortest possible time. This course basically is a solution to that, because in a situation where you have to plan an event, how planning, where you want to do a training, gather everyone, there's lunch, there's dinner, there's mid-dinner, you pay the experts. In that same time, you can be reaching literally 2,000 people in less than 2 hours, and they are gaining the same knowledge. They are able to practicalize it. They are able to use it even immediately, because someone can just finish taking a course and she has to attend to a bet in the next, the same day, and she's able to apply it. And that way we see that they are empowered, they are equipped with the knowledge that they need to save newborn lives, which is, I think is a major goal for all of us here, to save the lives of these babies. These babies hold so much potential, even for where Nigeria is headed, even for where we are headed as a country. We cannot be losing these babies, and this course has shown so far, from what we've heard, that it is an answer to that. And I believe that hearing him, myself, I took the course personally. I enjoyed it, and it was literally, I wanted to take it again, but then I just, because we were working, I just continued hearing from them. So it was exciting, and the feedback has been really promising.
Thank you, Amarachi. And some bottlenecks that other partners identified, the partners in Gombe and Kano State, were also calling the health workers to verify their phone numbers. And we did provide airtime to the health workers, either before they took the course or after they took the course. Yeah. Now, it was a small amount. I believe here in FCT it was 1,500 Naira. And in Gombe it may have even been only 1,000. But regardless, that process of following up with the health workers to identify which number we needed to send the airtime to, that was a bottleneck in this approach, and that's going to be something that's difficult to scale up to, for example, an entire country. So, and I believe also these were some challenges encountered here in FCT. So basically, that's a long way of saying, while there were a lot of good things about the pilot, there are also some things we'd like to improve upon. So just to step back for a moment, I just want to remind myself more than anyone that our overall objective here is to support the government and your initiatives to train PHC-based health workers here in Nigeria. So I know that NEMSHIK has several programs, be it CRISP or SQUATS, that this might align with. We would, of course, seek your guidance on that. But we want to deliver courses that cover many different preventable causes of death eventually, but we are initially focusing on maternal and child health. And really the overall objective is to provide really high quality and life-saving training at low cost. What HealthLearn is proposing for our organization to do as next steps are as follows. We think there are two key uncertainties in this model. First of all, does this actually change health workers' clinical practices? We don't know yet. We have some anecdotal evidence. We have some reports that this does change what they're doing, but we'd like to measure that. And second of all, we'd like to understand if we can find more efficient and sustainable implementation models. So those are the two key questions, and that's what we propose to work on next. The implementation model that we have discussed with partners is to work with the LGA MCH coordinators, the LEMCHIK, SEMCHIK, to identify facility focal points in each PHC, and then ask those focal points to join a WhatsApp group. And instead of having a WhatsApp group of all of the health workers who are asked to take the course, have a WhatsApp group of the PHC focal persons that's managed by an implementing partner, and then ask those PHC focal persons to cascade the course into their facilities. So they will say, okay, there are 5 people in my facility that should take the course, and they will actually request that those people take the course. So that's what we propose as something we'd like to explore as an implementation model. How we would do this in practice is we might start with about 20 or 25 PHCs in each of the states where we've already worked, and we would just see how that works and then report back to all of you, because our overall goal is to have a model that we can hand to the government and that could be implemented across the country, while we continue to focus on what we do well, which is create these courses. And the second thing we'd like to do is to find a local partner, probably an academic partner, but possibly an NGO partner, who can help us to do a small-scale study of directly observed clinical practices. So this would be done before and after health workers take the course, so we can see, are they actually implementing what they've learned. This could be a direct observation of actual births, or possibly a simulation to start. We don't think that this will give us an overall answer as to whether or not this actually saves lives, but it will at least move us a step further to understanding if even just a simple training can change practice. So that's what we hope to do, and there are a few things that we'd like to ask of all of you today. First of all, we need your feedback. So we'd like the feedback on everything that we've shared. Second of all, as a next step, we'd like to make the course available to anyone who wishes to take it here in Nigeria for the next year. So we can commit to making it available from January to December of 2024, and of course we would seek your endorsement of doing that. Second of all, we think that a substantial incentive for health workers could be continuing professional development, and so we would like to liaise with the professional bodies, potentially working with you, with your support, to actually have this course accredited for CPD. Now, I understand this process may take months, so it would probably be a process that we would start in the next 6 months, but we may not finish it. Third, this course is designed for Nigeria specifically. We have identified a few things we'd like to improve in the course, so we want to go back to the newborn subcommittee and share just those revisions for their feedback to ensure that it does continue to align with guidance. The 2 things that I would highlight would be, first of all, we'd like to add a little bit more infection control content to the course, a little bit more about how to prepare for a birth, ensuring that the mother washes her hands, ensuring that the health worker understands the moments of hand hygiene. That's actually the major change we'd like to make. Then secondly, we think that we could make some tweaks around the guidance for syphilis testing and treating, because we've heard feedback from some facilities that they handle that all inside of PHC, so we want to adapt and cover that. And then the second piece of this request is, this is of course dependent upon your team's feedback, but if you're willing to and interested, we would be very happy to place the Ministry of Health and NPHCDA logos on the course and the course certificate, and potentially pursue pathways for recognition of health workers who actually take this type of training. And then finally, we have a goal of offering more courses. We have the capacity to create more courses, especially in RMNCH. And so we see this as an opportunity, if there are new guidelines that are coming out or particular areas where your teams have identified that you would like to see more training, that we could collaborate to develop new short courses that cover those topics. We don't envision expanding the existing courses and making them bigger, but instead continuing to offer many short courses that cover different topic areas. So we've spoken far more than we intended to, and now I'll stop. And I would just like to say thank you for hosting us. Thank you for your support of this pilot, and we look forward to your feedback.
Thank you so much for the presentation. It's a very brilliant initiative. Like, the world is evolving, and a lot of things I learned online these days. I myself, I do courses that I develop my capacity basically and strictly online. So
Great.
people have changed career because of online courses. So online courses are taking the world day by day. So it is a really brilliant initiative. So I really appreciate that you conducted a testing first before you want to scale up. However, some questions I had was this type of course, right? The Qs and the JQs. their ability to use technology can be challenging. It's a factor that you have to consider to use technology. In fact, some of them may not even be able to, click a link. As far as the link is not clicking directly on their WhatsApp, they don't know how to copy the link to their browser. Someone has to show them. So, and a lot of them participated in this training. So, do you consider this as a what do you call it, a confounding bias or something that could have affected the results you get, especially with their completion rate and all those things, right? So, and when we are thinking of scaling it up, it's also something we have to consider. How are we sure all of them have phones that can access WhatsApp? Some of them use phones that cannot access the internet at all. Lots, in fact. Lots of them may not, have the ability to follow the course to the end and all those things. So, what changes? What solution are we going to think to apply to this to solve this and make it actually?
Great. Do we want to take other questions, or shall I answer questions?
I think we can take all the questions.
Okay, great.
Madam Asabe, do you have any comments?
Regarding the technology is considering the identity of education, issues and issues. So just like they are selected, that's my main area of concern as well.
Dr. Zara, any questions?
Yeah, I had a question, but I think because of the accreditation, immediately they answered it, he called my attention. I had written my question, it was basically on the direct observation of clinical practices. Because I was wondering then, how would you now assess that they are actually practicing these things that they have learned correctly? Who is there to observe them? So these are the things, and I saw that you have a plan for that, so maybe you could discuss more on that.
So, thank you, Dr. Marshall. We started all of this while at the ministry, and some questions have been raised. So going forward, you said something about this course being a refresher course. It's almost like it for some of these health workers. So I don't know, like how many times can they take this course? Because it has to be. Is it something that has to be often? Because it renews, like it's a refresher course. It helps them to also build their capacity. Apart from building their capacity, just like a retainment of knowledge. So like how many times do they really need to take this course? Is it just a one-off thing, or you can take it as long as they do it so that at least they get the knowledge more, their knowledge refreshed? I think other persons have been taken care of.
Okay, I want to thank Dr. Marshall and Amarachi, yes, for the presentation. You were there at the implementation level, and you did what you could. It was challenging, I can understand. I will point out some areas of my concern, and let's see how it's possible for us to work around it. A good one, you were able to take the course, because I know when we were looking at the modules that time, the whole course was not really ready for use. I think I would have also taken the course. All right, so that way one will be able to know some of the shortcomings even before you get to the field. So, but I'm concerned about the attrition rate, especially in FCT. You said about 70% completion.
87% completion.
FCT was 75%.
Yeah.
Right. So attrition of 25 is quite high. It's quite high. So we need to find out what exactly was the reason why 25 out of the whole people that were supposed to participate did not complete the course. I think that's an area we should really look at. Then let us also look at those areas, especially Gombe and Kano, where of course they had better completion rates. How were they able to achieve that? One would expect naturally that people in the FCT will be more enlightened, more inclined to new things, new technology and all that, but on the contrary, we are seeing something different. So I think we should look at that. Then I wanted to also ask, was there no form of restriction, during the deployment of the tool? Because it was meant for 300 people. But eventually I shared to my friends and they were able to take the course and all that, and we ended up having like 350 something, right? So what was the form of check that was put to make sure that this course was supposed to be restricted to only people that received the links and all that? I think that's also important, so that it won't be like anybody else can just go and get the link and take the course and get a certificate. So I think we really need to look into that. Then lastly, I wanted to also know, was there any form of kind of scoring system that entitles somebody to getting a certificate, or anybody that takes the course but at the end of the day just earn a certificate? So I think there should be some form of scoring system whereby if you achieve certain degree of maths, for example, if you get 70% or 80 or as the case may be, then you are entitled to a certificate. So I think these are some of the areas I needed to talk about.
Okay.
Okay, thank you. Very rarely do you see partners, usually when they come and you have initial engagements with you and they go, you never see them. So kudos to you. You really tried coming back to, give us a debrief of your findings. In terms of the questions, Dr. Gato took one of my questions. Secondly, I'd like to know, was there a difference in performance of health workers that had been trained before on the E1 course and then in terms of performance? Because that would really help us to know whether do we need to outline a set of criteria and say, for you to participate in this short online course, you must have participated in this critical intensive course, or can this be for just any health worker regardless of whether they've been trained primarily or not? Then for the data, do you have information on how much data was required to complete the course and then the monetary value of that data? In terms of your asks, we're happy to collaborate with you. Like Dr. Badmon said, this is innovative and the whole world is going to acknowledge it. So we're happy to collaborate as long as we're sure that this would lead to improvement in capacity and will not be abused, by health workers. We also have to think of how to control this, because we have some health workers that are not licensed to, for example, care for a newborn, and then simply by getting the knowledge, it can open up cockery and all of that. How do we also control it? Yeah.
Okay. Great. Wonderful. So, unless there's other questions, we can start at the beginning, I think. So, the first question was around this kind of course being offered to J-Choose. They may have more limited access to technology, comfort with technology, and how do we feel about that? And so, what I would say is there's two things. I was somewhat surprised actually that we had a completion rate over 60%, because we have not, in any pilot we've run with the hypertension training, infection control training, we've never actually been able to establish